Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast we're talking about GP premises. I'm joined by BMA England GP committee member Dr Gaurav Gupta, who's the chair of Kent LMC and the GP committee lead for premises. In this conversation, Gaurav talks about the terrible state of GP premises in England, how we've reached this point, and why the government needs to invest in the primary care estate if it's serious about growing the workforce, improving the NHS, and moving more care into the community. He also explains what the new premises cost directions could mean for practices, the problems facing practices based in NHS Property Services buildings, and why GP premises ownership should still have an important role in future plans for the primary care estate. I'm delighted to be joined on the podcast now by Dr Gaurav Gupta, who's a GP in Kent. He's the chair of Kent LMC and a member of the BMA GP committee and the BMA National Council, and is the GP committee lead for premises, and he's here today to talk about GP premises and what the future could hold under this Labour government. Thank you so much for coming on the podcast.
Thank you for inviting me, and hello to all the listeners.
So we're always talking about the terrible state of GP premises, but what exactly is going on with GP premises in England at the minute? What do we know about the buildings practices are operating out of?
Right, so we did a survey, the BMA did, and we found that half of the practices reported that their premises were not fit for their present needs. But this number alarmingly goes down to 2 in 10 when we ask the practices if they were fit for the future. So 2 in 10 practices only think that their premises are fit for the future. You would have seen the recent Darzi report, and that highlights that there is a shortfall of 37 billion of capital investment in NHS. This billions of pounds of capital under investment in NHS could have, amongst other things, rebuilt or refurbished every single GP practice in the country. We know that 20% of the primary care estate predates the founding of NHS in 1948, and 53% is more than 30 years old. All of this is happening against a background of GP teams providing more patient contact than they've done ever before, and the workforce and training numbers are also increasing. So simply put, we have run out of space.
Why are we in this position? What's gone wrong?
The main issue is that we've had no meaningful investment in general practice since the Estates and Technology Transformation Fund, also known as ETTF, which was launched about 10 years ago in 2015. The fund, even though it had a lot of problems, it was a very frustrating bureaucratic process to access the funding, was the last big capital injection of cash into GP estate. The government has also introduced ARRS, which is part of the Primary Care Network Enhanced Service, and this requires more space. Consultation rates are higher than ever before. We are doing 1.5 million approximately contacts with patients every single day in general practice. And the government wants to increase GP training numbers and double the number of medical school places. So without adequate space, we can't do any of this. We can't accommodate these trainees and we can't accommodate that workforce. And we are not being able to provide the care and the service that we want to provide to our patients.
You touched on there that's not been any investment, but have practices been able to secure any kind of funding for improvements to their premises in recent years?
Not really. There has been no central funding to be secured, and accessing local funding has been very, very difficult. It is often heavily bureaucratic and time-consuming, and this is not possible for already overworked GP partners. Due to the ongoing restructuring in NHS, ICBs have lost local estates expertise, and many of them are unable to cope with local requirements. If you also look at the housing development that's going around the country, the funding that comes with it, which is Section 106 and Community Infrastructure Levy, these funding rules are very difficult for local GPs to access capital. We know from recent reports that there are billions of pounds of unspent funding, but GPs can't access that due to red tape. One particular example of barriers is the ridiculous situation GPs are facing in NHS Property Services buildings. It is even more difficult for GPs in those buildings to access funding because they are in service charge disputes and might not have a signed lease. Ironically, even though these buildings are owned by the Department of Health and the Secretary of State, NHS Property Services and CHP are both treated as private landlords. So their GP tenants can't access Section 106 or SIL or other funding because they have a dispute and therefore no lease. This is absurd because in fact, the Department of Health is losing the funding. And it feels like NHS England and Department of Health are shooting themselves in the foot due to this. There are a lot of issues. There isn't any funding. And when there is a little bit of funding, it's very difficult to access.
Yeah, I'm going to come on to talk a little bit about the NHS Property Services disputes and things like that in a bit. But firstly, perhaps worth thinking a bit about what the current government has said about what it wants to do. So the budget which we've seen quite recently. Obviously, lots of problems with the budget, but one potential positive with it was it promised a £100 million fund to upgrade and improve existing GP premises. Clearly, that is nowhere near enough money. But has the BMA had any information about how practices will be able to access this money, which practices are likely to get that funding? Do you know anything about how that's going to work?
Well, the answers are quite short on this one. 100 million is nowhere close enough. The number needs to be in billions. And we don't know the process yet. So we're still waiting for the details of how this funding will work, and we'll respond to this in due course. But at the moment, we have no further information.
How much funding do you think we need to turn things around? What does the BMA want to see from the government in terms of a proper plan for the primary care estate?
So what we really need is a significant funding, which is easily accessible. That's an important point. And ring fence for general practice, which is another important point. If you again look at the Darzi report talking about £37 billion of NHS underinvestment in capital, this is what we would have required to match peer countries' level of capital investment over the last many years. So if you look at what is happening in terms of our estate being really old, 20% being pre-NHS and 53% being more than 30 years old, this task is massive, but the cost is going to get exponentially more difficult to fund if we don't do something about this now. So we need significant funding. We need it to be easily accessible, and we need it to be ring-fenced specifically for general practice.
Are you hopeful that this new government understands the importance of GP premises? One of the three big mantras it's got is like this idea of moving hospitals to community. So obviously it wants to provide more care out of hospitals and create this neighbourhood NHS. Do you think it understands the importance of GP premises if it actually wants to do this?
Firstly, yes, I'm hopeful. You have to be hopeful. We have a government that wants to fix the broken NHS, and I'm really hopeful that BMA can work with them to achieve this. Again, referring to various reports, including the Darzi report, there has to be significant investment in general practice estates if any of those ambitions held by the government are to be achieved. Royal College of General Practitioners did a report called Fit for the Future, and there it says that of those who reported that their premises are not fit for purpose, 1 in 3 said that this is because the space is inadequate, and 9 in 10 said that they do not have enough consulting rooms. So these are very basic requirements. Without these consulting rooms and space, none of this is going to happen. We want to see more GPs. We want to see more medical students and trainees in workforce, but that means increasing the capacity to accommodate these people.
Yeah, definitely. One thing that has changed with premises over the past year is that finally we've seen some new premises cost directions that were published, and these have taken a really long time to come out. Can you explain why they are so important to premises and what some of the key changes are?
So there are a few positive changes that have come out of the updated premises cost directions. The first is that commissioners will now be able to award improvement grants of up to 100% of project value. Previously, this limit was 66%, and the permitted maximum value of grants has also been increased. So this gives commissioners the ability to fund more significant improvements to GP premises. The second thing is there are changes to abatement period and also to the guaranteed minimum use period that comes with these grants. These are positive changes for GPs when they're looking at what they need in terms of extension of their premises or making new premises. And finally, the other positive thing is new commissioner powers, subject to capital, of course, to support contractors who may wish to retire but cannot find a successor partner from within the practice. So a situation which we commonly refer to as the last partner standing problem. So we are pleased to see some of these positive steps which will help GPs and partners who want to buy into property owning partnerships. We hope that these will help GPs in advancing their services, but there is no additional funding at the moment going into ICB budgets. So it is a little bit of a struggle to see what benefits will actually land from these new premises cost directions.
If there finally is money coming through, then it's probably a good thing that these premises cost directions are there, isn't it, compared with what was there before?
Yes, as you said, it's conditional to having the funding. These changes are great, but without funding, there is little that can be done. There also isn't a consistent mechanism for ICBs to undertake the lease liabilities to avoid the last partner standing situation. Additionally, because of ongoing restructuring, we are not sure that many ICBs will have the expertise to do this. BMA will continue to work with all stakeholders to make sure that these improvements are actually realized and GPs on the ground are seeing the benefits.
One of the big issues relating to GP premises in recent years, you touched on it earlier, has been the problems around service charges for practices in NHS Property Services buildings. The BMA has been quite involved with legal challenges around this. Firstly, for people listening to this who may not be aware of it, what exactly is the problem around service charges?
So the issue with service charges for GP practices in buildings owned by NHS Property Services stems from significant changes that came with Health and Social Care Act in 2012. In 2016, NHS Property Services implemented their policy, also known as Consolidated Charging Policy. And this policy aimed to levy charges against surgeries for rent, maintenance, service charges on the basis of recovering all their costs. And in the years that followed, BMA started to receive hundreds of reports from practices that practices believed NHSPS was charging them unjustly, i.e. not in accordance with their existing contractual terms, and much higher levels than what they were paying before. And there's been independent scrutiny of this as well. So National Audit Office in 2019, it identified serious flaws in NHSPS's operations. And the Public Accounts Committee also later concluded that NHSPS was set up to fail. So despite recommendations to resolve these issues, including agreeing on tenancy terms with practices, problems with transparency and historical billing, these things didn't get better. In 2020, BMA was forced to take legal action to support some of our practices against NHS Property Services. In a sense, the situation has left many GP practices struggling with historic debt and unmanageable service charges. We also know that some practices have been forced to hand back their contracts. The BMA has persistently urged the government to address the funding shortfall, but there is no concrete support at the moment, and it's leaving these practices in severe financial strain at the moment.
Do we know how many practices are in that position? Do you have any idea about the figures on that?
So we think about around 20% of the practices are in NHS Property Services building. The number has fluctuated because some of these practices have either left or have handed back their contracts. So I'm not able to give an exact figure, but the estimates are that around 15 to 20% of the practices are in NHS Property Services building.
Yes, this is a really big issue, isn't it? It's not just some peripheral thing. That's a lot of practices that are affected by this then, isn't it?
It's a massive issue. It also had implications not just for these practices, but also neighboring practices and ICBs, because of course these practices tend to be in larger health centers. And so by definition, they will hold a larger list size. And if a practice of this size hands back their contract, it then actually destabilizes the whole area.
The BMA has been very involved in the legal challenges around this. How have those worked and what's been the result of those? And what do they mean for other practices?
So I'm really proud to say that the BMA successfully supported 5 GP practices in legal proceedings in NHS Property Services. This was to get clarification on the basis on which NHS Property Services calculates service charge. So we refer to the policy that NHS Property Services implemented around 2016. During the legal case, NHS Property Services actually conceded in court that this consolidated charging policy had not been incorporated into or retrospectively varied the tenancies and existing service charge obligation. In plain terms, basically, every single tenancy has to be discussed and decided upon on its own merits. NHSPS must have regard to the individual facts and circumstances of the practice concerned. This includes written and unwritten occupancy agreements that those practices might have. So the case and the subsequent settlements resulted in significant reductions in the amount of debt NHSPS sought to reclaim from the practices. This included a reduction of 80% in one of the cases. I won't go into the details of these individual cases, but anybody who's interested can go on the BMA website, and there's a wealth of information that you can find on the BMA website on this issue.
What's the position for practices affected by this issue? Now, other practices, not these ones that have been involved in this case. Does this case have any implications for them, or will every practice be taken on its own merit, as it were? And what would you like to see overall done to resolve this problem?
So every practice will have to be treated on its own merit. This case does not set a precedent for the wider system. There might be some learning from the case, but the judge was very careful in avoiding setting precedents for the wider system. Practices in this position must liaise with NHSPS to resolve their situation on a case-by-case basis. And they need to try and agree an outstanding debt agreement and a sustainable charging schedule going forward. However, practices must also be mindful that any agreements do not jeopardize their existing legal rights and do not put their future sustainability at risk. And I would really like to stress this point in every case. We encourage you at the BMA to seek independent legal advice before agreeing to anything. GPC England would like to see a new contract from the government, which makes funding available to cover all service charges and management fees for all practices. We feel this is crucial to secure the viability of GP practices as we go forward, and we might have a new contract, and we are looking for increased funding for our clinical work as well. As the owner of NHS Property Services, Department of Health has the powers and must change its policy around how it charges general practice. The current policy is leading to practices getting into significant difficulty at handing back their contracts. This is just absolutely perverse. We are worried that other practices might also face closure if Department of Health does not change the way NHS Property Services operates. And if the government does not address the funding gap, there is a risk of premises closures and practice closures all over the country.
It really does just show how important GP premises are to everything, really. Such a big cost for practices, and potentially the way things are set up at the minute doesn't really address those things, like you say. So it sounds like premises are going to be kind of quite a big part of contract negotiations and the way the BMA is looking at how the contract could go in the future. Is that right?
I think premises is definitely one of the mainstays of how the profession moves going forward, how it works, how we provide services. If you look at what Labour wants to do, it wants to do this shift of services out from big hospital buildings into the community. And where are you going to put them if you don't have the premises? So without premises, none of these ambitions from the government or from BMA can be materialized. And if you ask practices consistently after workforce and workload, premises is the single biggest issue that affects them. Everybody needs a room to work from. And it's all good saying we're going to double the number of medical school places and we're going to increase trainee numbers. But where do you sit them? So by definition, GP registrars and trainees are supernumerary. That means they don't see extra patients, but they do need an extra room. So we need to have a GP registrar in a room where they can work from, which is fit for purpose for their use, but they're not adding additional capacity while they're being trained, which is absolutely the right thing to do. So how are we going to train more people without more rooms? We can't be expected to have efficiency savings in room space, more productivity out of room space, while we are also trying to train. By definition, it needs an upfront investment in premises if you're going to increase the workforce.
Aside from all of that, though, as well, it's just more stressful, isn't it, working in a building that's not up to scratch or doesn't work properly? And GPs have already got enough stress on their plate in terms of the workload they've got without having to worry about things like that.
I completely agree. I mean, your work hygiene is such a big thing. People feel so much better when we're working in buildings that are nice, that have got good ventilation, that have got good heating, good cooling, good IT. That is such a big thing for people. You know, the well-being depends on it. Our well-being depends on it. Our patients' well-being depends on it. There are studies and there's evidence to show that when patients are seen in new building, in new facilities, there are less complaints and there are less complications. So this is not something made up. You know, if you're working in a nice, modern environment, your work productivity will increase automatically.
One of the other things I wanted to talk to you about is obviously premises is a massive issue when it comes to GP partnerships. We know that the number of GP partners are falling, quite worryingly so. There's a lot of reasons why GPs might be put off becoming partners, but one issue that often comes up is premises. And, you know, obviously if you're a partner in a practice and a GP-owned premises, there's a cost of buying into that, and potentially there's all sorts of worries about last man standing. Can you explain a little bit why premises is seen as such a barrier to partnerships?
The first thing to say is that GPC England, we do not see premises ownership as a barrier to partnership model. The reason why we are struggling, and this has become an issue, is due to the chronic underfunding of the GP contract itself. The underfunding and the unlimited liability faced by GP partners, that is what is resulting in general practice becoming financially unsustainable. And then fewer GPs want to become partners as a result. Premises, of course, adds additional stress if you're already underfunded and you have unlimited liability, but it doesn't have to be like that. If premises are funded properly and there are good reimbursement and there is a good rolling scheme for uplifts of premises, then I think it is a positive thing that GPs own their own buildings because they're invested in their local community, their work environment is better. So I think it's the underinvestment, both in the GP contract as well as in the premises, that is leading to this situation. But we think that premises ownership in itself is not a barrier to partnership model if everything was funded properly.
When we come to talk about things like last man standing, that's what people fear, isn't it? Being the last man standing in a partnership and then being saddled with a lot of liability around the premises, whether or not you're in an owner-occupied building or a rented building. That is part of the concern, isn't it, for people?
There is some relief now in the premises cost directions. We need to wait and watch how that unfolds and what happens on the ground. But there is now a power that is with the ICBs/NHS England to take over that liability if there is that last partner standing situation arising. Premises ownership in general can be a positive incentive for GP partners. It gives us control over our working environment. It makes us part of the local community. It also can realize significant benefits to patients, GPs, our staff, and the wider healthcare system. So I think we really need to start thinking of premises as a positive thing rather than just as a liability. I think the problem is the underinvestment and the way it has been ignored for a long time.
A little while ago, there was this talk that maybe we could move to a future where GPs didn't necessarily own their own buildings. But is that something you see happening in the future, or would you really advocate against anything that would change the way things are at the moment?
So we at GPC England recognize that one size doesn't fit all. And being in rented premises might be more suitable for some practices, for some GPs. However, we don't believe at all that mandating all GP practices to operate from rented premises as a default option is a good thing. We have seen the difficulties already faced by hundreds of practices when they are tenants in premises which are run by landlords such as NHS Property Services and CHP. The option of having a choice is vital. We should not mandate how practices operate and what kind of premises they operate from. If we talk to GP partners who are running sustainable, good, viable practices, owning their practice and having the choice and the option to make changes at short notice, for example, during COVID times, can be a hugely positive thing, not just for GPs, but also for our patients.
If there are GPs listening to this and they are in buildings that need improvement, maybe they own their own buildings, they are in buildings that need improvement, and there is likely to become some money at some point, we don't know when, what advice would you give them now? Is there things they could do now to get themselves in a good position to be able to get access to that money later on?
I think the main thing to start doing is to start getting your plans ready. Speak to the ICB, ask them what is their priority for your area. Is there an increasing population size? There's a lot of house building going on across the whole country. So that will also give you some kind of an idea of what's happening in your local area. You can look at the council plans. You can see what their plans are about building more houses in your area, what schemes have already been approved. You can also ask the council what Section 106 funding is already sitting there with the council. So I think it's prepare, and prepare early. So you might think, why am I doing this when there is no funding right on the horizon now? But if you're prepared, then it'll make your life a lot easier. So even if you don't want to spend money in getting surveyors to write a plan for you or in legal fees, at least get some kind of a plan in your head, put it down on a paper, how many extra rooms you might need, how many extra trainees you might be able to accommodate, what is the house building in your area. So just be a little bit more prepared, start thinking about it. So when it comes the time to put an application in, you're not starting from scratch.
And just quickly on the Section 106 money, there has been problems, hasn't there, in the past with GPs actually getting access to that money? Because so this is money that should come through when there's new developments. The property people should be paying money to the council, and then the council should be using that money to expand infrastructure, which includes GP services, to meet the needs of these new people that are moving to the area. Are GP practices finding it easy to access that money, or is there still a lot of problems around that?
So you're absolutely right in stating how it should work. Unfortunately, that is not the practical reality on the ground. And a lot of this is just bureaucratic hassle. There's also postcode lottery. Some ICBs are better than others in drawing this funding from Section 106 from the council. In some areas, it's more difficult. Then you have to apply for it as you would apply for a grant. And then that is a process in itself. You have to do documents, submit them to the ICB. So the process is unnecessarily complicated. And there is a good argument to be made about automatic drawdowns and automatic investment into general practice. And that is what we would like to see, a rolling investment plan. So if you look at how many houses are being built, I'm sure my experience in my area can't be unique. Every single field I drive past has got houses going on it. So we know we need more general practice states to cope with that increasing demand that's coming our way. And I think it will be very useful for the government as well as for NHS if there was an automatic, easy process for this funding to be drawn down.
Right. That does sound very sensible. Thank you so much for coming on the podcast, Gaurav. It's been really great to talk to you today. Thank you.
Thank you so much, Emma.
Well, that's it for this week. Thanks for listening, and thanks so much to Gaurav for taking the time to talk with me. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting primary care, including our coverage of the England LMC's conference, which takes place on Friday. on our website at GPonline.com.